There we go. Okay, so what happens when a traditional practice transforms to operate as a patient-centered medical home? What does that look like? Next slide. We think it looks a lot like this diagram, and each one of these icons and each one of these arrows has specific significance in the patient-centered medical home, and we'll talk about them in a little more detail. But what I often say to doctors is the patient-centered medical home is not your dad's medical practice. Think different. You're not just going to be reactive to the patients that come to you. You're going to be active with your patients, with the population that you manage, with the medical neighborhood, and with your own data and management and measurement. And ultimately, and we're able to see this now in a lot of areas of the country, this results in better outcomes for patients and financial rewards for the practice and savings to the system. We're going to focus specifically on savings to the system and how the patient-centered medical home affects those savings. There are a ton of other benefits in terms of patient satisfaction and medical staff satisfaction. But we will focus primarily on cost savings today. The patient-centered medical home has a different kind of relationship with patients. It's a team, and everyone on the team has his or her own responsibility to the patients. The patient-centered medical home also has a longitudinal relationship with that patient and with its whole population over time. So even though I, the patient, am only actually in the medical home maybe a couple of hours a year, I have another 8,000 hours a year where I'm not in the medical home, and yet I'm still your patient. And the medical home is able to use modern tools to track patients, to know what's happening with their health, to contact them when necessary. The medical home also sets up active partnerships with the medical neighborhood, and we'll talk about that very specifically. But care coordination for that patient is a major responsibility of the medical home. And then we talk a lot about management and data as we help practices make the transition. Get them to think about the data that they can produce themselves, the other data they can use, and how they use data to continually manage and improve their practice. This is a wordle of some of the terms that we use when we're talking about the patient-centered medical home. Many of them are terms that practices aren't used to using frequently, and we continually throw this at them and keep them learning how to think a little differently about their relationships with their patients. So a lot of our practices have asked for a roadmap, have said, you know, show me where I'm exactly going. I want to know when I get there. So we've conceived this chart, which has a lot of detail behind it, as you can imagine, that shows actually 7 areas in which the practice needs to transform. And for each of those areas, what we have observed is that practices go through basically 3 steps. First is understanding the concept and the expectation, and really setting their own expectations for where they want to go within each of these areas. And then the second stage probably is the longest one, where the practice actually develops new skills and new ways of operating in order to make those expectations come true. The third stage is actually gathering evidence to see how well they've met their expectations. Using that evidence to show actually the outcomes for their patients, to show NCQA or other organization that's reviewing them for recognition, how much progress they've made, and also ultimately to show the outcomes that they're producing for the system. And we're going to talk about those outcomes in a minute. So looking at these areas one by one, the first is teamwork, which is the heart of the medical home. It really requires a culture change to a point where the whole staff is operating as a team rather than as a doctor with a bunch of busy people buzzing around the doctor. Everyone on the team has important contributions. Everyone on the team has a responsibility to the patient, and everyone on the team relies on tools to keep up with what they're all doing and to communicate with the patient, to use data and manage. Access and continuity is the next area, and I would just say that our areas are roughly based on the NCQA standards. We have a little bit different emphasis, but we find that to be a very good rubric for understanding the medical home. So the access function looks at how do you respond when your patient comes to you. First of all, the concepts that you need to develop and expectations you need to develop are around how quickly do you want to be available? How much time are you going to give each patient depending on her needs? How soon do you expect to be able to respond on the phone? How much are you going to be able to consolidate and strengthen that patient's relationship with one particular provider? Then the skills that you need to develop are how to manipulate your system, how to use your patient portal for exchanging information, and how to track what's happening so that you're up to the minute and able to both respond to patients' needs for access and record what happens. And then the evidence stage where you actually collect evidence, you say, okay, to what extent did we meet our goals? To what extent were we able to respond to all of our patients' needs? And then the change then to the system, and as I said, we're going to focus on the changes that have to do with cost savings. So the changes from better access that we look for when we work with clients, that the system is looking for, and that the payers are interested in reimbursing for, is better access for patients that leads actually to fewer ER visits. I think there are a number of other impacts of this. That's an important one. Then population management, I think, is the area that makes a patient-centered home the most different from a traditional practice. A traditional practice is reactive. They'll set up an appointment when the patient calls them. If the patient's out in the world those other 8,000 hours a year, letting her health go to hell, not taking care of her chronic conditions, the patient-centered medical home needs to be on that. They need to maintain registries. They need to decide on guidelines that they're going to use to actually follow up with their patients. And they need to build the skills to manage registries and to reach out to patients, to make team members responsible for reaching out to patients. And then they need to collect the evidence to see how they did. Did they actually do better against those evidence-based guidelines? And then the change to the system, did they actually better control? Are their patients in better control of their chronic conditions and therefore less likely to experience exacerbations and to wind up in the hospital or the ER? The next concept is very key to the patient-centered medical home. It's the active working together and partnership between the provider and the patient for better care management. And this is where the patient-centered medical home really focuses on those patients who have extra needs, who have chronic conditions, who are on, multiple medications, who are for one reason or another identified as high risk. And the concepts that the medical home needs to understand is setting the criteria for high risk, figuring out a systematic way to identify the patients who need care management, who need self-management support. They need to build the skills to work with patients and both incorporate evidence-based guidelines into what they do, but also help the patients reach towards those guidelines in what they do. The evidence that the patient-centered medical home then collects is the actual updates and progress towards the patient's goals, the goals that are set collaboratively with the patients, as well as, again, admission and ER rates, where care management is working better and the patient is engaged. The system expects to see lower utilization of high-cost services. There will be more utilization of the medical home. That's a good thing. There may be more utilization of medications to get the patient on the right medication and staying on the right medications. But the system is looking for lower utilization of the hospital and the ER. Then care coordination is probably the most difficult part of transformation to the medical home that some of our practices see, particularly independent practices who try to set up a relationship with their local hospital so that they automatically get discharge notices and data on what's happened to their patients in the hospital. This can be a real challenge. The concepts here are having an agreement with the other parts of the medical neighborhood, and that's the lab, the x-ray, the hospital, the specialists that you use, the pharmacy, behavioral health, other services to which you refer the patient. It's really putting the medical home and the patient in the center and coordinating all the patient's care.